Well, even though within, for example, the Spanish myeloma group and the clinical trials of the cooperative group, we have used both immunophenotypic and molecular methods, from fluorescent PCR a few years ago, then nasal PCR, and more recently NGS. I must say that, so we are fan of molecular techniques. I must say that usually on routine practice we use flow cytometry. But whenever this question appears, my immediate answer, and this has been my answer for many years now, is that most important, or more important than the technique, is to really use methods that have been well validated, standardized, are optimal, and also recommended by the International Myeloma Working Group. I think this is the most important message. Well, I think that both questions are very, very much aligned, and considering that both methods have been well validated, optimized, standardized, considering that this is a reality, and in myeloma we should feel very fortunate because we don't have one but more than one method. There is also imaging using PET-CT, so plenty of methods to monitor treatment efficacy. I think that providing you have the same performance between methods, then the choice is really related to their advantages and limitations. You can imagine that each technique has its own advantages and limitations, and also the availability and the resources you may have in order to use one or other technique. So providing you are using the most sensitive, validated, accepted method, the choice in between one or the other will depend on the availability, the type of sample that you have, if you have the sample at baseline or not, as well as the resources you may have in your institution.